Good evening. It's Dr. John Bennett, televising from dark Miami. Today we have another conference in the Conference of Pediatric Neurosurgery, a collaboration between Neurosurgical TV and the Deepak Gupta of the Department of Neurosurgery of the AIMS hospitals in India, AIIMS. He's assembled a great cast of speakers, and we have another great speaker tonight. We have Alma Griselda Ramirez Reyes. She's going to be talking about cerebellar mutism. And first, let me introduce the panel. Good day, Norma. Could you introduce yourself, please?
Oh, yeah. Hello, my name is Norma. I'm a physician, general physician, and I run a medical students chapter in my country, medical students with interest in neurosurgery. That's through AANS.
Very good, very good. Welcome, Norma. And Simon.
Hello, my name is Simon Downs. I'm a medical student and psychologist in Tokyo. Looking forward to the presentation. Thank you very much.
Okay, a member of the team. I love your background. Okay, Griselda, welcome, and it's all yours.
Thank you very much. My name is Griselda Ramirez. I am a pediatric neurosurgeon working at Mexico City. It's my pleasure to be here with you, sharing my experience about the cerebellar mutism. And wow.
Yes, we can see it.
Yes? Okay. The posterior fossa syndrome is a devastating complication of surgery encountering the patients operate on for midline tumors in the posterior fossa. It's characterized by a profound neuropsychological disturbance, the central manifestation of which is cerebellar mutism. This was first reported in 1979 by Hirsch after a posterior fossa tumor resection. And the autodiagnosed patient show some improvement with time. Many of them don't fully recovery. The impact of posterior fossa syndrome on patients, family, and healthcare providers is considered. The cerebellum participate in language learning, mental and social function, and the mutism is considered severe coordination of the volitional motor aspects of speech. And all these disorders is observed in the patient with posterior fossa syndrome. The cerebellar anatomy and function is very important for understand the several disorders. The anatomical location in left lobe have function in visual, spatial, executive functions. The right lobe is implicated in language. The anterior lobe have implication for truncal ataxia and hypotony. The posterior lobe is have relation with appendicular ataxia, hypotony, tremor, and the vermis is related with emotions. The cerebellar involvement in reading ability development is really important in children from birth to 12 years. We performance sensorimotor networks, language and learning networks, and we performance sensorimotor cognitive integration. Also, the cerebellum plays a role in high order behaviors like neuropsychiatric and genetic disorders like attention deficit, autism, developmental dyslexia, Fragile X syndrome, and Down syndrome, and schizophrenia. The most important for neurosurgeons is the posterior fossa tumors. This is really common in children, principally the medulloblastoma, pilocytic astrocytoma, and in some cases ependymomas. The posterior fossa syndrome is important understand this cerebellar mutism, also known as posterior fossa syndrome, is a relatively common complication of posterior fossa surgery for primary brain tumors in children. Many children with cerebellar mutism experience long-term adverse neurological, cognitive, and psychological sequelae and require extensive interdisciplinary support. This graphic was performed for Dr. Gudrun Adbottir in Iceland for describe posterior fossa syndrome. This is really complex syndrome, include neuropsychological, neurological, and language speech. And the most important and severe is cerebellar mutism. The studies with tractography and functional MRI have important functions for describe the pathways for language in the patients, and the cerebellar thalamus-cerebral connections impact on working memory. The principal pathways is the interrubral thalamocortical pathway and the interrubral olivary pathway. These studies describe dentato-thalamocortical tract. The proximal components, dentate nuclei, superior cerebellar pedunculus, and their deposition in the mesencephalic tegmentum of the efferent cerebellar pathway are often invaded by posterior fossa tumors and are prone to surgical damage from radical resection. Efferent fibers from the dentate nuclei leave the cerebellum through the superior cerebellar peduncle, decussate in the mesencephalic tegmentum, and synapses in the ventral lateral and ventral anterior nuclei of the thalamus. The corresponding postsynaptic neurons project to widespread cortical areas, including the primary motor, premotor, and prefrontal cortex. Bilateral damage to the proximal efferent cerebellar pathway has the potential to disrupt the efferent cerebellar signals and deprive the cerebral cortex of cerebellar input in a fairly global fashion. Functional disconnection of this area may cause a complex neuropsychological disturbance, such as posterior fossa syndrome, with significant impact on various aspects of neurocognition. This is really interesting diagram about the Gillian-Muller triangle with relation to the proximal efferent cerebellar pathways, and the posterior fossa syndrome is a complex functional disturbance affecting cortical areas involved in cortical neurocognitive process, which developed remotely from the site of surgical injury through a transsynaptic reflex mechanism. Diastasis is defining as sudden inhibition of function in an area of the brain remote, but anatomically connected through transsynaptic neural pathways to the site of primary injury. This cerebellocerebral diastasis is the most common form. The hallmark features of diastasis are hypoperfusion, decreased oxygen consumption, and hypometabolism. is frequent. Also is frequent in ischemic stroke. These are cases of medulloblastoma in the midline of cerebellum, and occupied all the foreventricle and compressed the brainstem. This is other studies of hemorrhage for observed dilation and compress the brainstem and extending into the spinal conduct. Several studies are performed about the language and the cerebellum, and this interesting study with clinical symptoms and ataxic dysarthria and apraxia speech, and they performance the difference between dysarthria and apraxia of language. This is a cases of the posterior fossa tumors and approaches, and the most the cerebellar approach is a more safety technique for remove posterior fossa tumors in the midline of cerebellum. Several neuropsychological tests are performed for study the patient with in children's aged 3 use subtests of the Wesley press calls, polishing revised naming vocabulary test of the differential abilities scale, and tailor children's stories, their visual motor integration, and guardian expressive one word. In children's aged 5 to 16 years, use subtests Wesley intelligence scale for children revised, automatic sensories, Boston naming test, sentence memory and learning, very visual motor test, and Reyes storage complex figuring. This is another study about the neurocognitive outcome 12 months following in cerebellar mutism syndrome in pediatric patients with medulloblastoma. And the most important function in this test was the broad attention and processing speed and cognitive absence are the more statistical significant. And the cerebellar mutism spectrum include for study the cognitive, affective, behavioral, language, speech, neurological, motor, and somatic. This is really important in preparative symptoms, and it's important performing these studies and postoperative symptoms in children. In the last 30 years, performance all these studies in all the world about the cerebellar mutism and posterior fossa syndrome. In our hospital, in the last period of 2011 to 2015, we have 33 cases of posterior fossa tumors with age 3 to 15 years old, male 23, family 7, 3 patient deep. And the most common tumors was medulloblastoma and ependymoma, and in 3 cases low-grade astrocytoma, and 1 case of glioblastoma multiforme, and 1 case of rhabdoid teratoid tumor. This patient was studied in preparative and postoperative, and the follow-up for 12 months. They have neuropsychological disorders in 10 cases, and in the follow-up persisted in 4 cases. The irritability was common in 10 cases and persistent in 3 cases after 12 months. The cognitive was the same in 5 cases. Affective behavioral in 4 cases. Neurological motor was the most frequent disorder in 30 cases. Are better 24 after 12 months. In neurological somatic disorder, we have 22 cases preparative and only 2 cases in the follow-up. In language speech, only have 4 cases in preparative, and in post-operative increased to 6 cases, and in follow-up only have 4 cases with language and speech disorders. And cerebellar mutism, previous, we have 9 cases and are better after surgery. In cerebellar after surgery, only 10 cases. This was transitory in 3 cases. In cerebellar mutism after 12 months, in 7 cases, and long term in follow-up, only 6 cases. Children with cerebellar damage are particularly at risk for long-term neuropsychological dysfunction and require active rehabilitation measures. Reducing surgery-related morbidity should be the next goal to reduce posterior fossa surgery-specific deficit. And neuropsychological and logopedic rehabilitation is necessary in all cases for performance better prognosis in these patients. We invited yours to the next Congress for pediatric neurosurgery in Latin America the next month. Thank you very much.
Very much.
Okay. I'm sorry. I was just doing some other tasks. Thank you very much. Thank you very much, Griselda. Excellent, well illustrated, good pictures. And thank you for promoting the conference at the end of the month. Next month in pediatric neurosurgery. Okay, yes. I'll open it up and I'd like you to meet Deepak Gupta. He's the organizer of this conference. This is Griselda Ramirez Reyes from Mexico City.
Hi, good morning.
Hello, thank you very much.
Must be late evening for you out there.
I'm sorry, what did you say?
What's the time there in your country?
9:30 at night. It's 1 hour earlier than Miami, so it's not too bad. It's not too bad for her.
I have a question for you. These children with cerebellar mutism, how do they progress? I mean, what is the usual time when they improve after surgery?
Did you hear that, Norma? Did you hear that, Griselda?
Okay. ¿En cuánto tiempo los evaluamos?
Yeah, you said, how do these patients progress with mutism? How long do they take to improve? ¿Cuánto tiempo para mejorar?
¿Cuánto tiempo?
Para mejorar.
Okay. After the surgery, in some cases, for 4 weeks to 8 months.
8 months after. Okay, I'm sorry.
What?
I'm sorry to interrupt you. You said eight months
Yes,
after the
but
surgery, that's when they start to improve?
yes, for these cases, we spend the time for 4 weeks to 8 months, and they a therapy for language, and they for language and for learning, we performance with the mental health system for help these children, and we don't use the medicines like pharmacological bromocriptine. We don't use this. We only use the rehab rehabilitation for language.
Okay.
So
Okay,
what percentage
Simon or I'm sorry, Dr. Gupta, do you have another question?
what percentage of children remain with some deficits?
¿Qué porcentaje de pacientes queda con problemas? Con déficit.
Approximately
Con déficit.
40. Approximately 35 to 40%.
¿Qué porcentaje?
But many,
¿Qué
de 35 a 40%.
Okay. Okay.
Es elejado.
Okay.
But many patients.
Okay, I'm sorry. I guess we got lost there in translation. Okay, Norma or Simon, do you have any comments or questions?
Yes, please. Thank you very much for your presentation. I was reading that although it's much less common in adults, that in adults after 7 to 8 weeks that they often see complete resolution. In children, do we see complete resolution? Is that possible, or are they always left with some deficit?
May I also ask, is it related to the type of tumor, or it's purely a surgical insult? The cerebellar mutism, the incidence, does it vary with medulloblastomas, ependymomas, pilocytics? Is it different in the 3 different tumors, or it is purely a surgical issue?
Okay. Okay. Okay, Norma, do you have any comments or questions?
Okay, well, it was a very nice lecture. Thank you, Dr. Griselda. And I just have a little question. Is prognosis directly related to the age of the children? I mean, younger children, do they have better prognosis? And older children may have a worse prognosis? Or are there any studies, or is it just different, or is it not?
Did you hear that, Norma? You hear that, Griselda?
The prognosis for little children is better to respect the old children's for performance, the language, the behavioral, cognitive is really different. And this is really important if the patient have the schisis, cerebellar cerebral is the most important factor for development, the language, cognition, learning, and neuropsychological disorders. This pathway is the most important in this patient.
Okay. Okay, muy bien. Muy bien. Okay, muchas gracias, Griselda, por tomando este tiempo. I'm sorry. Thank you very much for taking the time to give this presentation.
No, thank you very much, John and Dr. Deepak Gupta for
yeah, maybe someday you'll
for
meet.
Sharing with me this aspect.
You know, Dr. Gupta, Griselda has been to India.
Yes, I have 3 times in India.
What part of India did you go to?
Goa, ISPN 2011.
No, I was only for traveling for tourists.
Okay. So you're invited to come to India anytime. We will be very happy to have you.
Yeah. Well, if you notice on her profile, she has a lot of pictures of her trip to India, mostly around New Delhi, right, Griselda?
Yes, I was in Delhi 2 years ago. For sure, Stanford. This is nice place.
That was just vacation, right? Not medical?
No,
It's solamente vacation. Okay, very good.
only for
Okay, we'll wrap up this conference, and we look forward to the next one, and you're all invited to stay.